You walk into clinical and you have 3 patients with abdominal pain. 1 has right upper quadrant pain, 1 has left lower quadrant pain, and 1 has epigastric pain. So which one do you prioritize? Well, if your brain jumps straight to anatomy, you're not alone, but that's where many students get stuck. The real question is not where is the pain. The real question is who is most unstable, who is most likely to deteriorate, and who needs our help right now. Well, today I'm going to take you through a simple process where you can learn to analyze abdominal pain just like a nurse. I call it the 4 Ps: pause, prioritize, plan, and prove. Let's use it to think together. Before jumping right into a diagnosis, let's pause and think a little bit and ask some important questions. What are the patient's vital signs? What do they look like? What are they reporting their pain to be like? Is it acute? Is it chronic? Did it come on rather suddenly? Does anything relieve it? And also GI complaints. Are we seeing any nauseousness, vomiting, bleeding, any abdominal distension, any guarding, anything that would lead us to understand the case better? Many students jump right into thinking about how body systems work. You don't want to do that though. That's understandable, Nico, but first, before you do that, you want to get a grasp of the whole picture. Now we prioritize. Let's compare our patients. Patient A, right upper quadrant pain, stable vitals, nausea after a greasy meal. Patient B, left lower quadrant pain, mild fever, overall stable with a history of constipation. And patient C, epigastric pain, pale, diaphoretic, blood pressure dropping. Which one is going to rise to the top? You got it, patient C. Why? Because instability beats location. This is where students grow fastest, when they stop chasing labels and they start prioritizing risk. Once you figure out who is the priority, then you're going to figure out what the plan might be. So what are we going to do next? Well, we certainly want to reassess vitals. We want to do a full focused pain assessment. We're going to notify the nursing instructor, the nurse on duty, the provider even if they're available. We want to anticipate orders and we want to get ready to perform safe interventions. True nursing judgment is not just identifying a problem, it is figuring out a safe solution, and that might mean staying with your patient until someone else can arrive. After our interventions have been completed, we have to prove whether it worked or not. We have to prove progress. So we're going to see, is the patient getting better? Is the patient getting worse? Is their pain improved? Are their vital signs unstable? Are they having new symptoms that we didn't know about that now changes the plan? Strong nurses reassess constantly, and wise decisions will show up with good outcomes. A common trap is jumping to conclusions, thinking it's right upper quadrant pain, so it must be gallbladder. Right, Nico? Well, maybe it's gallbladder, maybe it's not, and maybe that's our priority patient, but maybe not. See, good nurses don't just jump to those conclusions. They look at the stability of the patient and figure out how urgent the situation is. If abdominal pain questions make you freeze, just take a step back and follow the simple process. Pause, prioritize, plan, and prove. You don't have to know everything right now. You just need a simple process that'll get you out of the freeze frame and move forward. A special thanks to Tessa for today's visual aids and for Nico for sharing a student perspective. If you want more real clinical judgment scenarios, be sure to subscribe. Every week we work through a patient case together, And this is going to help you be able to think like a nurse under pressure.